Within this module on venous disease, we're going to look at the anatomy of the venous system. We'll go on to talk about the pathophysiology of venous insufficiency and some of the clinical signs that we see. And then we'll go on to discuss the complications of venous insufficiency in the form of varicose veins, venous ulcers, and then we'll go on to talk about the other different kinds of ulcers that we commonly see clinically. In terms of venous anatomy, we all know that veins carry blood from the body back towards the heart, and veins tend to accompany arteries with similar names. But we do find a few exceptions within the body. For example, we have the azygous system, we have our dural venous sinuses, and then within our limbs we have superficial venous systems along with our deep venous systems. On the right hand side of the screen you can see an image of the venous system within the arm, where we do have ulnar veins and brachial veins. However, we also have some more superficial veins in the form of our cephalic and our basilic veins. And there is that small anastomosis between the two of them of the median cubital vein, where we commonly take blood for venipuncture. As we continue more proximally, these veins do anastomose with our deeper veins, but we see a similar thing happening within the leg. Within the leg, along with our popliteal and our femoral veins, we also have our saphenous system. So the saphenous venous system is composed of our long saphenous and our short saphenous, or our greater and lesser saphenous veins, and they form part of the superficial venous system that runs in the leg. The long saphenous vein runs along the medial aspect of the leg and anastomoses with the femoral vein at the saphenofemoral junction towards the groin. The short saphenous vein runs on the posterior aspect of the leg, more or less in the calf, and anastomoses to the popliteal vein just inferiorly to the popliteal fossa. These veins are quite important to know because they're ones that we harvest quite commonly for different surgeries. So for coronary artery bypass grafts or arterial bypass grafts, these veins are commonly used. But they're also a common site for varicosities to occur. In terms of structural anatomy of veins, they're quite similar to arteries in the sense that they have a tunica, intima, media, and externa that generally follows the same principles. The intima has that smooth endothelial lining made up of those squamous epithelial cells. We have our tunica media that's composed of some smooth muscle cells, but a significantly smaller proportion of smooth muscle cells compared to arterial walls. And then our tunica externa, or adventitia, much in a similar way, is largely composed of fibrous connective tissue. The biggest difference between veins and arteries is that veins are adapted to function in the sense that they have valves preventing backflow. Without any organ before their origin to create any pressure within them, veins rely on muscular contraction from muscles around in order to propagate blood through their venous system and up towards the heart. When we talk about venous insufficiency, what we're saying by that is that the ability of the venous system to completely and adequately return blood from the peripheries back towards the heart is impaired. In terms of what this looks like clinically, we have a CEAP classification system, and this quite nicely tells us some of the clinical signs that we can see. As venous disease starts to progress, we start to get the development of edema, varicose veins, and we start to see significant skin changes over time. Legs will take on a particular inverted champagne bottle appearance as the fat around the ankle starts to become hardened and atrophied, a condition called lipodermatosclerosis. We also see deposition of hemosiderum within the legs, creating a dark reddish appearance. And eczema may start to occur as the skin breaks down, and there'll also be some hair loss. Towards the more advanced forms of venous insufficiency, you start to see skin breakdown and ulcer formation. And the CEAP classification groups those from C0 all the way up to C6, depending on which clinical signs are evident. In terms of things that can cause venous insufficiency, the biggest cause would be hypertension. So hypertension within the venous system creates vascular remodeling that we'll speak about on the next slide, and this is one of the largest causes. Cardiac failure, particularly right-sided cardiac failure, more commonly due to COPD or lung disease, creating a backflow of blood within the right side of the heart, can cause venous hypertension that also leads to venous insufficiency and venous remodeling. Two situations that can mimic venous insufficiency or generalized cardiac failure are when you have any ongoing renal disease or any hepatic failure. If you have any glomerulonephritis or excessive protein losses for the kidneys, or if you have an inadequacy of protein production in the liver, the blood will lose its oncotic ability to maintain fluid within itself. So fluid will naturally move into tissue spaces surrounding. And what you get is an edematous patient that has pitting edema, but actually does not have any cardiac failure or hypertension. And you get this clinically mimicked appearance of peripheral edema. So those two things don't cause venous insufficiency, but they're two things to be aware of because they can mimic it. In terms of the pathophysiology and how venous insufficiency occurs, it all comes down to hemodynamic changes within the veins themselves. High pressure creates shearing forces on the vessel, and in response to that, we get vasoactive response within the veins and cytokine release. Over a significant period of time, the cytokine release causes remodeling of the vein walls, and these matrix metalloproteinases that we'll come on to talk about in the aneurysm lecture play a key significant factor in this. So what happens over a chronic period of time with this cytokine release and this matrix metalloproteinase exposure is that we get remodeling of the muscular and elastic components in the venous wall. The collagen composition of the venous wall changes into a less readily reformable form of collagen. So although there is some distensibility in the vein wall, it's unable to recoil back to its original shape. And it's this type of collagen that replaces a large portion of the vascular smooth muscle cells. So these veins are also then less able to contract in response to pressure. The overall result of this is that the vein wall becomes dilated, less distensible, and because of this ongoing cytokine activity, extracellular matrix is more easily lost into surrounding tissue spaces. And the presence of extracellular matrix in the surrounding tissue spaces causes all of these skin changes that we see over a chronic period of time as we get further proteolytic and fibroblastic processes happening in surrounding tissue. The image on the right-hand side goes into further depth about some of the cytokine mediators involved in this process, but I've covered the general process now. We've already covered quite a few of the clinical signs that we see with venous insufficiency, but in terms of the symptoms that patients get, a lot of the time they'll be quite asymptomatic. They may complain of a little bit of intermittent swelling through the day, but a lot of the times this will be painless. But they tend to be asymptomatic until end-stage complications occur. Typically, patients may complain of leg pain, itching, and swelling as they're getting fluid accumulation within their legs. Over a period of time, they will start to get skin breakdown and ulcer formation, and although these are painless, patients may still notice them. The image on the right-hand side of the screen shows this inverted champagne bottle appearance that we discussed earlier, where you have this thin tapering of the ankles compared to the rest of the leg, as all of the fat is broken down. You can see this reddish-purple tinge to the skin as there are hemosiderin deposits in the skin creating this appearance. And you can appreciate on the right-hand side of the image at the back of the ankle, the skin appears quite dry and cracked. And these are all signs of venous eczema. In terms of complications that we get from venous insufficiency, the two that we see clinically are varicose veins and the formation of ulcers. So varicose veins are tortuous veins that you can see on legs. These can either happen in larger veins or in smaller veins and create these spider vein-like appearances on the limb that oftentimes are commented on as being unaesthetically pleasing. So they're quite common. About 1 in 4 adults will experience them in their lifetime, and they're more common as people get older. Other risk factors involve being female, being pregnant or obese, and any prolonged standing. So any condition that places excessive pressure on the venous system is likely to predispose the formation of varicose veins. And a key thing to note is that although varicose veins are relatively common, the vast majority of patients will have absolutely no symptoms with them. They're purely a cosmetic abnormality. In terms of the pathophysiology or why varicose veins occur, there's this quite commonly propagated theory that it's due to incompetent valves or broken or weak valves. The latest research is showing that this is actually not quite as true as it seemed to be. So we mentioned previously with vascular remodeling of veins that we get this venous distension due to a lack of muscle and also remodeling of different forms of collagen, and this makes the veins quite dilated and distended. Varicose vein formation occurs when we get this distension at the point of venous valve occurrence. The vein becomes dilated and essentially pushes apart the valves that are present. These valves are no longer able to oppose each other and prevent backflow, so backflow occurs and we get this tortuous dilatation of a vein that we call a varicose vein. When you clinically examine a patient, varicose veins are normally quite obvious to see, usually in the distribution of the long or short saphenous vein. If unable to visualize, you can normally feel them by running your hands over a patient's leg in that distribution. It can also be exaggerated by getting a patient to stamp their feet, and it's important to emphasize that for examining varicose veins, patients should be stood up. You can do some tourniquet tests to try and isolate the level of incompetence or generation of varicose veins. Due to the availability and ease of ultrasound nowadays, these tests are not done commonly clinically, however they're still quite good to be aware of. So the Trendelenburg test tests the level of incompetency within the superficial veins. So initially you'd have a tourniquet applied above the knee, have a patient lying down on the examination table, raise their leg to return all of the venous flow as much as possible, place the tourniquet above their knee, and get them to stand up. If a varicosity reoccurs at this point, it implies that the level of incompetence or the level of distension is below the level of the tourniquet. However, if it does not appear, then that level is above where the tourniquet is. You can continue to assess the level of incompetence by progressively moving the tourniquet down and repeating the test until you isolate that level. And Perthes test assesses the competency of the deep venous system. So in a patient with known varicose veins, in a similar way to the Trendelenburg test, you would raise their leg, try and return as much of the venous blood flow as possible, place the tourniquet around their leg, and get them to stand up and do some exercise, whether that's walking across the room and back, or that's raising themselves onto their toes and down. If their deep veins are competent, then you should see that their varicose vein starts to collapse as blood flow is forced down the deep venous system. However, if the varicose vein remains distended, it's a sign that the deep venous system may not be competent. This would have some clinical significance in deciding whether or not to harvest veins for arterial grafts or coronary artery grafts. But as I say, due to the high availability and ease of access of ultrasound nowadays, these tests tend not to be done so much. Managing varicose veins is largely conservative. The main complaint that patients have is that the cosmetic appearance of their legs is not appealing due to the presence of the varicosities. But varicose vein removal results in quite high reoccurrence rates of the varicose veins. So unless varicose veins are causing quite a lot of pain in the legs, then they tend not to be operated on. When we do decide to operate, there are a few different options that we can use. The traditional historical way of removing varicose veins was avulsion and stripping. So the small cuts would be made on the legs and the veins would be physically removed. Other options that we have nowadays are the insertion of a probe to radioablate the veins from the inside out, and sclerotherapy, which is the injection of inflammatory chemicals to create a chemical response and seal the veins off. The other complication that I'd like to go through for venous insufficiency is the formation of ulcers. So in its most generic definition, an ulcer is the breakdown of skin in the formation of a wound. However, there are different types that we have that can relate to different causes and present different symptoms. The first type is a venous ulcer. So we already mentioned that this was due to venous insufficiency and the presence of extracellular matrix and cytokines in the surrounding tissue space. This led to different fibroblastic and proteolytic changes that ultimately, over a long period of time, lead to skin breakdown. Venous ulcers tend to be quite shallow. They tend to be quite sluffy in appearance. They have a lot of dead tissue surrounding them. And they also tend to have quite sloped edges. In terms of the location they're commonly found on, they tend to be found on the shins, and this is called the gaiter region of the legs. The mainstay of management with these ulcers is to keep them dressed with compression bandages and dressings that will allow them to heal. By addressing the underlying cause of venous insufficiency or attempting to return as much of the blood flow from the legs as possible, we can facilitate a better environment for the wounds to heal in. Ultimately, they are quite slow to heal. And district nurses tend to dress these out in the community, and by monitoring their size over time can assess whether they're progressing or regressing, which is a key hallmark of the management of their venous insufficiency. Another type of ulcer, in contrast, is an arterial ulcer. And this is due to arterial insufficiency, or fundamentally a lack of blood flow due to limb ischemia. These are commonly found on pressure areas of the foot, or they're present on the dorsum of the foot, as you can see in the image on the right. In contrast to venous ulcers, these ulcers are quite well circumscribed, they're quite deep, and they have a punched out appearance with very clear wound margins. Due to the lack of blood flow to the area, you may also find that these patients have associated areas of necrosis in their feet, which you can appreciate on the great toe and the middle toe in the image on the right. Typically, these ulcers are very, very painful, which helps to differentiate them from diabetic ulcers. Along with addressing the underlying cause of the arterial insufficiency and attempting to increase blood flow to the area, these are managed by simple dressings. The third type of ulcers to address are diabetic or neuropathic ulcers. So when these occur, it tends to be a sign of poor diabetic control. And because of the neuropathic quality to these ulcers, implying that the nerves are damaged, patients often don't notice that they have ulcers until they're picked up incidentally. In appearance, they tend to be quite similar to arterial ulcers. They're normally in pressure areas of the feet or areas of injury that have occurred to the feet. They're quite deep with well circumscribed areas, but the key hallmark that defines them from arterial ulcers is they are non-painful. And alongside aiming to improve diabetic control, these are also managed with dressings in the community. In patients that have multiple comorbidities and mixed disease, you may find that some ulcers don't fall nicely into that classification. You can get different mixed ulcers where they are exhibiting features of both arterial and venous ulcers and maybe some neuropathic element as well. And the management of these ulcers becomes ultimately more complicated. The main risks and complications with having ulcers are that ultimately they are an exposed wound. There's always the risk of infection within an ulcer, and if their underlying process is not managed effectively, then there is the risk of progression of ulcer in terms of size and number. An acknowledged complication, particularly of venous ulcers, where you have this constant overgrowth and overturn of cell division, is that malignancy can occur. You can get squamous cell carcinomas occurring in sites of venous ulcers. So this is just a few pictures to go through, just to show you some different ulcers in different situations. So this is an ulcer that's present on a person's ankle. It's quite irregular in shape, relatively shallow with some sloughy edges. So this would be a good example of a venous ulcer. You can also see at the peripheries of the image, there's this scaling of the skin as well, some venous eczema. This ulcer is present in the middle of the person's foot. It's quite deep, quite well circumscribed and punched out. Looking at the nature of this person's foot being generally quite swollen, this would be more consistent with a diabetic foot ulcer. This person may have what's called a Charcot foot or a Charcot joint, which is a complication of poorly managed diabetes. This would be another good example of a venous ulcer. Just on the medial side of someone's ankle, quite shallow and irregular, and you can see that there's also some other ulcerated areas more proximally on the ankle, indicating that this person's venous insufficiency may not be being managed adequately. This is an ulcer on the dorsum of someone's foot. It's relatively deep with well circumscribed edges, and you can see just distally there are 2 toes that are quite blackened and necrosed. This would be a perfect example of an arterial ulcer. And this one is an image of the base of someone's foot. Another deep, well circumscribed ulcer there. This one, without talking to the patient, I think would be difficult to classify. This could be either a diabetic or an arterial ulcer. The main hallmark feature would be if there's any pain present with it. And that summarizes up essentially everything that we need to cover in terms of venous disease for vascular surgery. Just a quick summary slide to remind you that venous insufficiency occurs as a result of venous hypertension and vascular remodeling. Varicosities occur when venous hypertension causes valves to no longer oppose each other, and this is in contrast to the traditional theory of incompetent valves. And varicose veins are only indicated for surgical treatment when they're symptomatic. And a final point on ulcers is that they come in 3 different varieties, and wound management is key in all of these cases alongside addressing the underlying disease process.